Why is epinephrine the drug of choice for anaphylaxis while norepinephrine is not? What is epinephrine reversal and why does blood pressure fall after giving an alpha blocker to a patient receiving epinephrine? And if epinephrine and norepinephrine are both catecholamines, why do they produce different effects on blood pressure and heart rate? In this lecture, we'll answer all of these questions by understanding the receptor pharmacology of epinephrine and norepinephrine, learning how to interpret cardiovascular tracings, and applying these concepts to real clinical scenarios. Now in this section, we will begin studying adrenergic drugs. Now let's move on to the classification of adrenergic drugs. Just as we saw with cholinergic drugs, adrenergic agonists can also be classified into direct-acting, indirect-acting, and mixed-acting agents depending on how they produce their sympathomimetic effects. Direct-acting adrenergic agonists produce their effects by binding directly to adrenergic receptors and activating them. Because they act directly on the receptor itself, these drugs do not require an intact sympathetic nerve terminal or the release of endogenous norepinephrine to produce their effects. Some of these drugs are highly selective for a particular receptor subtype. For example, phenylephrine selectively stimulates alpha-1 receptors. Clonidine primarily stimulates alpha-2 receptors. Other direct-acting agents are less selective and can activate multiple receptor types simultaneously. For instance, epinephrine stimulates alpha-1, alpha-2, beta-1, and beta-2 receptors. Norepinephrine stimulates alpha-1, alpha-2, and beta-1 receptors, while isoproterenol acts on both beta-1 and beta-2 receptors. Regardless of their selectivity, the defining feature of direct-acting drugs is that they act directly on the receptor itself. Indirect-acting adrenergic agonists, on the other hand, do not directly stimulate adrenergic receptors. Instead, they increase the availability of norepinephrine at sympathetic nerve endings, allowing the body's own neurotransmitter to produce a greater response. In other words, these drugs depend on the presence of a functioning sympathetic nerve terminal because their effects are mediated through the release or preservation of endogenous norepinephrine. They can achieve this in several ways. Some drugs, such as amphetamine, promote the release of stored norepinephrine from sympathetic nerve terminals. Others, such as cocaine, inhibit the reuptake of norepinephrine back into the nerve ending, allowing it to remain in the synaptic cleft for a longer period and stimulate receptors more effectively. Another mechanism is the inhibition of enzymes responsible for catecholamine metabolism. For example, MAO inhibitors such as selegiline and COMT inhibitors reduce neurotransmitter breakdown, thereby increasing the availability of norepinephrine. Finally, there are mixed-acting adrenergic agonists, which combine both mechanisms. These drugs not only stimulate adrenergic receptors directly, but also increase the release of norepinephrine from sympathetic nerve terminals. The classic example is ephedrine. Let's begin with the two most important catecholamines in pharmacology, norepinephrine and epinephrine. The main goal of studying these two drugs together is to compare and contrast them. At first glance, they may seem very similar because both are naturally occurring catecholamines and both stimulate adrenergic receptors. However, despite their similarities, they produce markedly different effects on the cardiovascular system. In fact, one of the most common sources of confusion for students is figuring out which receptors are activated by epinephrine and which are activated by norepinephrine. Instead of memorizing receptor tables, let's understand the logic behind it. The previous lectures on the sympathetic nervous system laid the foundation for everything we're going to discuss in this lecture because we're simply applying concepts that you've already learned. As you know, both epinephrine and norepinephrine are catecholamines. However, epinephrine primarily acts as a hormone and is released from the adrenal medulla directly into the bloodstream, whereas norepinephrine primarily acts as a neurotransmitter and is released from sympathetic nerve terminals. We also learned that adrenergic receptors can be broadly classified as either innervated or non-innervated. Innervated receptors are located close to sympathetic nerve endings and can be reached directly by norepinephrine when it is released from the nerve terminal. Non-innervated receptors, on the other hand, are not closely associated with sympathetic nerve endings and are mainly activated by catecholamines circulating in the bloodstream. Most alpha-1, alpha-2, and beta-1 receptors are innervated receptors. Therefore, when norepinephrine is released from sympathetic nerve terminals, it can readily reach and activate these receptors. Beta-2 receptors are different. Many beta-2 receptors are functionally non-innervated, meaning they are not easily reached by norepinephrine released from nerve endings. As a result, norepinephrine has very little effect on beta-2 receptors under normal physiological conditions. So, if you are wondering which receptors norepinephrine primarily activates, the answer is alpha-1, alpha-2, and beta-1 receptors. Beta-2 receptors are generally not significantly activated by neuronally released norepinephrine. Now let's compare this with epinephrine. Since epinephrine is released directly into the bloodstream, it does not depend on a nearby nerve terminal to reach its target. It can circulate throughout the body and interact with adrenergic receptors wherever they are located. Therefore, epinephrine can activate alpha-1, alpha-2, beta-1 and beta-2 receptors, including those beta-2 receptors that are not directly supplied by sympathetic nerve endings. So, in simple terms, norepinephrine mainly acts on alpha-1, alpha-2 and beta-1 receptors because it is released locally from sympathetic nerve terminals, whereas epinephrine can act on alpha-1, alpha-2, beta-1 and beta-2 receptors because it is delivered through the bloodstream and can reach receptors throughout the body. Now that we understand which receptors are activated by norepinephrine and epinephrine, we are finally ready to predict their physiological effects. And rather than memorizing a list of actions, we're going to analyze them step by step using cardiovascular tracings. Before we start analyzing the effects of norepinephrine and epinephrine, let's first understand the tracing itself. So imagine we're working in a laboratory. We have a heart connected to a pressure recording device. Every time the heart contracts and ejects blood, as the pressure rises and the recording pen moves upward. And when the heart relaxes and fills with blood, the pressure falls and the pen moves downward. As this process repeats beat after beat, the pen continuously draws a wave-like pattern on a moving piece of paper. This recorded pattern is what we call a tracing. Now let's focus on a single wave. As the ventricle contracts, arterial pressure rises and reaches its highest point. This peak represents the systolic blood pressure. After the heart relaxes, arterial pressure begins to fall and eventually reaches its lowest point just before the next heartbeat. This lowest point represents the diastolic blood pressure. Then the next heartbeat comes along, pressure rises again, and another wave is formed. So every peak on the tracing corresponds to systolic pressure, and every trough corresponds to diastolic pressure. Just watch what happens to these peaks and troughs when a drug is given. Do they move up? Do they move down? Does the distance between them increase or decrease? That's where most of the answers come from. Now between systolic and diastolic pressure lies another very important parameter called the mean arterial pressure or MAP. Think of MAP as the average pressure in the arteries throughout the cardiac cycle. On the tracing, it is not located at the midpoint between systolic and diastolic pressure. Instead, it lies closer to the diastolic pressure because the heart spends more time in diastole than in systole. As pulse pressure is the difference between systolic blood pressure and diastolic blood pressure. So, when looking at a tracing, also pay attention to the height of each individual wave. The greater the distance between the systolic peak and the diastolic trough, the wider the pulse pressure. Conversely, if the peaks and troughs move closer together, the pulse pressure becomes narrower. The next thing we want to learn from the tracing is the heart rate. Here, we simply look at the distance between consecutive waves. Think of each wave as representing one heartbeat. If the heart starts beating faster, more heartbeats occur in the same amount of time, so the waves move closer together on the tracing. In other words, the spacing between successive peaks becomes smaller. On the other hand, if the heart rate slows down, fewer heartbeats occur in the same amount of time, so the waves become farther apart. Finally, let's talk about how to recognize a change in blood pressure on a tracing after a drug is administered. Imagine that before giving the drug, the tracing is oscillating around a certain baseline level. Now suppose we administer a drug and both the systolic peaks and diastolic troughs begin to move upward. In that case, the entire tracing shifts upward, telling us that blood pressure has increased. Conversely, if both the peaks and troughs move downward, the entire tracing shifts downward, indicating that blood pressure has decreased. Now that we know how to read a tracing, let's put that knowledge to work and see what happens when we administer norepinephrine. Before looking at the tracing itself, let's try to predict what should happen based on the receptors that norepinephrine activates. We know that norepinephrine primarily stimulates alpha-1, alpha-2, and beta-1 receptors with essentially no significant beta-2 activity. For understanding the tracing and action of norepinephrine, the two most important receptors are alpha-1 and beta-1. Because alpha-2 receptors are primarily located on presynaptic nerve terminals, whereas alpha-1 and beta-1 receptors are located directly on the target tissues. For example, alpha-1 receptors are found on vascular smooth muscle, while beta-1 receptors are found in the heart. Therefore, when alpha-1 and beta-1 receptors are stimulated, they produce immediate and direct effects on the organ, such as vasoconstriction and increased cardiac activity. In contrast, alpha-2 receptors mainly regulate neurotransmitter release from the nerve terminal rather than producing major acute direct effects on the blood vessels or heart. That's why the changes we see on the tracing are largely due to alpha-1 and beta-1 receptor stimulation. Let's start with the alpha-1 receptors. When norepinephrine stimulates alpha-1 receptors on blood vessels, vasoconstriction occurs. As the arterioles constrict, total peripheral resistance increases, and whenever total peripheral resistance increases, blood pressure rises. Therefore, we can predict that the entire tracing should move upward because the mean arterial pressure is increasing. Now let's look at the beta-1 receptors. These receptors are located in the heart. Stimulation of beta-1 receptors increases heart rate. So before even looking at the tracing, we would predict that the waves should move closer together because more heartbeats are occurring in the same amount of time. In other words, we would expect tachycardia. But beta-1 receptors do more than just increase heart rate. They also increase the force of ventricular contraction, which increases stroke volume. As the ventricle ejects more blood with each beat, systolic blood pressure rises. Therefore, we would expect the systolic peaks on the tracing to move higher. Since pulse pressure is the difference between systolic and diastolic pressure, an increase in systolic pressure would also tend to widen the pulse pressure. So, based on beta-1 stimulation alone, we would expect to see three things on the tracing: the waves moving closer together due to an increased heart rate, higher systolic peaks due to increased contractility, and a wider pulse pressure due to the increase in stroke volume and systolic pressure. Therefore, we would expect to see an upward shift in the tracing, waves move closer together, higher systolic peaks, and an increase in pulse pressure. Now let's not forget what we discussed in the previous lecture about the baroreceptor reflex. Up to this point, we've been looking only at the direct effects of norepinephrine, based on beta-1 stimulation and based on alpha-1 stimulation. But the body doesn't simply allow blood pressure to rise without responding. As soon as norepinephrine causes a significant increase in blood pressure, the baroreceptors in the carotid sinus and aortic arch begin firing more rapidly. This activates the baroreceptor reflex, leading to an increase in parasympathetic activity and a decrease in sympathetic activity to the heart. The result is reflex bradycardia. And remember how bradycardia appears on a tracing. Instead of the waves moving closer together as we predicted from beta 1 stimulation, the waves now move farther apart because the heart rate slows down. In other words, the direct beta 1 effect is trying to increase the heart rate, while the baroreceptor reflex is trying to decrease it. In fact, if the rise in blood pressure is large enough, the reflex bradycardia can completely override the direct beta 1 mediated tachycardia. This is why the classic norepinephrine tracing shows a marked increase in blood pressure accompanied by a decrease in heart rate. However, it's important to understand that reflex bradycardia is not a direct effect of norepinephrine. It is a compensatory response produced by the body. If we were to block the parasympathetic reflex, for example with muscarine or a ganglionic blocker, we would unmask the true beta 1 effect of norepinephrine and observe tachycardia instead. So when looking at a norepinephrine tracing, always think of two forces acting at the same time. Alpha 1 receptors are raising blood pressure, beta 1 receptors are trying to increase heart rate, but the rise in blood pressure triggers the baroreceptor reflex, which slows the heart down. The final heart rate that you see on the tracing depends on which of these effects predominates. One final point, and it's important. Since norepinephrine has virtually no beta 2 activity, it cannot produce significant vasodilation. Therefore, norepinephrine can never lower blood pressure. Its vascular effect is always dominated by alpha 1 mediated vasoconstriction. So the blood pressure either rises or remains elevated, it does not fall. This is an important difference from epinephrine, which does possess beta 2 activity and can produce vasodilation under certain circumstances. Now let's move on to epinephrine. Unlike norepinephrine, which primarily stimulates alpha 1, alpha 2 and beta 1 receptors, epinephrine stimulates all four major adrenergic receptors, including beta 2. This makes the cardiovascular effects of epinephrine a little more complicated because the final response depends on the dose being administered. One more thing to remember, beta receptors are generally more sensitive to epinephrine than alpha receptors. Therefore, at lower concentrations, beta effects tend to predominate, while at higher concentrations, alpha effects become increasingly important. Let's start with low-dose epinephrine. At low doses, the beta effects dominate, especially beta 1 and beta 2. Beta 2 stimulation causes vasodilation, particularly in the skeletal muscle vascular beds. As total peripheral resistance falls, mean arterial pressure decreases. So on the tracing, the entire tracing tends to shift downward. At the same time, beta 1 stimulation increases heart rate and contractility. So on the tracing, we would expect the waves to move closer together and the systolic peaks to rise. So the entire tracing tends to shift downward while the heart rate increases. In other words, low-dose epinephrine produces tachycardia with a fall in blood pressure. If you compare it with drugs, it behaves very much like a beta 1, beta 2 agonist such as isoproterenol. Now let's gradually increase the dose. As the concentration rises, alpha 1 receptors begin to contribute. At this point, beta 2 mediated vasodilation is trying to lower blood pressure, while alpha 1 mediated vasoconstriction is trying to raise it. These two opposing effects partially cancel each other. As a result, mean arterial pressure changes very little. However, the beta 1 effect on the heart is still very much present. Therefore, on the tracing, the most prominent finding is tachycardia along with increased contractility and a higher systolic pressure. The blood pressure overall may remain close to baseline because the alpha 1 and beta 2 vascular effects are balancing each other. In many ways, medium-dose epinephrine behaves like a beta 1 agonist drug similar to dobutamine. Finally, let's consider high-dose epinephrine. At high concentrations, alpha 1 receptor stimulation becomes dominant. Now vasoconstriction outweighs beta 2 mediated vasodilation, causing total peripheral resistance and blood pressure to rise. Therefore, the entire tracing shifts upward, just as we saw with norepinephrine. Beta-1 receptors are still increasing heart rate and contractility, so we would initially expect tachycardia and higher systolic peaks. However, once the blood pressure rises sufficiently, the baroreceptor reflex comes into play. Just as we discussed with norepinephrine, reflex bradycardia may develop and partially or completely oppose the direct beta-1 mediated tachycardia. So if you step back and look at the big picture, low-dose epinephrine looks like a beta agonist. Medium-dose epinephrine looks predominantly like a B1 agonist, and high-dose epinephrine begins to resemble norepinephrine because alpha-1 mediated vasoconstriction becomes the dominant effect. Now here's an interesting problem. At high doses, epinephrine starts looking almost identical to norepinephrine. Both can produce significant alpha-1 mediated vasoconstriction, both can increase blood pressure, and both may even trigger reflex bradycardia through the baroreceptor reflex. So if you were looking only at the cardiovascular tracing, distinguishing between the two could become very difficult. So imagine you're solving a board question and both norepinephrine and epinephrine are among the answer choices. How do you decide which one is correct? At that point, you need to stop looking at the cardiovascular effects and start searching for another clue. The clue is beta-2 activity. Remember, epinephrine has significant beta-2 receptor stimulation, whereas norepinephrine has virtually none. Therefore, if the question mentions bronchodilation, relaxation of bronchial smooth muscle, increased glycogenolysis, increased gluconeogenesis, lipolysis, or any other classic beta-2 mediated effect, the answer must be epinephrine. So whenever you are stuck between norepinephrine and epinephrine, ask yourself one simple question. Does this drug show evidence of beta-2 activity? If the answer is yes, think epinephrine. If the answer is no, norepinephrine becomes much more likely. Now you might be thinking, that's fine if the question tells me about bronchodilation or glycogenolysis. But what if it doesn't give me any obvious beta-2 clue? That's where one of the most famous concepts in autonomic pharmacology comes in, the phenomenon known as epinephrine reversal. Let's build this step by step. Start with norepinephrine. Ignore alpha-2 for now because it doesn't contribute much to the acute cardiovascular effects. So norepinephrine is essentially an alpha-1 and beta-1 agonist. Epinephrine, on the other hand, stimulates alpha-1, beta-1 and beta-2 receptors. Now let's perform a little experiment. Suppose we give an alpha-1 blocker such as phentolamine. By blocking alpha-1 receptors, we remove the vasoconstrictor component of both drugs. So what happens next? Let's look at norepinephrine first. Once the alpha-1 effect is blocked, only the beta-1 effect remains. Therefore, we may still see an increase in heart rate and cardiac activity, but there is no beta-2 mediated vasodilation to lower blood pressure. As a result, the hypertension disappears, but the blood pressure does not fall below normal simply because norepinephrine has no significant beta-2 activity. Now compare that with epinephrine. When we block the alpha-1 receptors, the beta-1 effect is still there, so the heart continues to beat faster and more forcefully. But unlike norepinephrine, epinephrine still has beta-2 receptors available. And what do beta-2 receptors do? They cause vasodilation. So the moment we remove the alpha-1 mediated vasoconstriction, the previously hidden beta-2 mediated vasodilation becomes unmasked. Blood vessels dilate, total peripheral resistance falls, and blood pressure actually drops. In other words, a drug that was initially causing hypertension can now produce hypotension simply because the alpha-1 effect has been blocked and the beta-2 effect is now dominating. This phenomenon is called epinephrine reversal. The blood pressure response is literally reversed from a pressor response to a depressor response after administration of an alpha blocker. And that reversal is proof that the drug possesses significant beta-2 activity. So whenever a question describes a fall in blood pressure after giving an alpha blocker, think carefully. If the blood pressure simply returns toward normal, norepinephrine is still possible. But if the blood pressure actually falls because of unopposed beta-2 mediated vasodilation. That's a classic clue pointing toward epinephrine. Epinephrine reversal is not just an exam concept. It actually illustrates an important principle that can arise in real clinical practice. Imagine a patient in shock, whether it's cardiogenic shock following a myocardial infarction, anaphylactic shock, or another form of circulatory collapse. In such situations, drugs like epinephrine may be used to support cardiovascular function. As the patient is being treated, we continuously monitor parameters such as blood pressure and heart rate. Suppose that while titrating epinephrine, you notice that the blood pressure is rising excessively and the heart rate is beginning to slow down. What does that tell us? It suggests that the alpha-1 mediated vasoconstrictor effect has become dominant. The marked vasoconstriction is driving the blood pressure upward, and the resulting hypertension is activating the baroreceptor reflex, producing reflex bradycardia. Now think about why that could be a problem. Excessive vasoconstriction may reduce blood flow to tissues that are already struggling with poor perfusion. At the same time, reflex bradycardia can reduce cardiac output, which is the last thing we want in a patient whose circulation is already compromised. This is where the concept of epinephrine reversal becomes clinically relevant. If the alpha-1 mediated vasoconstriction is contributing to the problem, blocking the alpha receptors removes that vasoconstrictor component. Once the alpha-1 effect is taken away, the beta-2 mediated vasodilation of epinephrine becomes unmasked. The blood pressure falls, peripheral resistance decreases, and the cardiovascular response is essentially reversed. So once again, epinephrine reversal is the use of alpha-1 blocker to reverse hypertension to hypotension in patient receiving too much epinephrine. I hope this is clear now. Up to this point, we've mainly focused on the cardiovascular effects of epinephrine and norepinephrine because that's what we see on the tracing. However, remember that epinephrine has one receptor that norepinephrine essentially lacks, the beta-2 receptor. And this single receptor is responsible for several important physiological effects. Before we discuss these beta-2 mediated effects, let's once again keep this big picture in mind. For example, if you're running away from a dog, it would be beneficial for your airways to dilate so that more air can reach the lungs. This is exactly what epinephrine does through beta-2 receptor stimulation. When epinephrine stimulates beta-2 receptors in the bronchial smooth muscle, the airways relax and widen, allowing more air to flow into the lungs. This is something norepinephrine cannot do to any significant extent because it lacks meaningful beta-2 activity. Now the obvious question is, why should we care that epinephrine causes bronchodilation? The significance becomes clear when we think about situations in which the airways become narrowed. For example, during an asthma attack or an anaphylactic reaction, bronchial smooth muscle contracts, reducing the diameter of the airways and making it difficult for air to reach the alveoli. As the airways narrow, airflow decreases and the patient may develop wheezing, shortness of breath, and hypoxia. By stimulating beta-2 receptors, epinephrine relaxes the bronchial smooth muscle and opens up the airways. This reduces airway resistance and allows more air to reach the lungs with each breath. In other words, bronchodilation improves ventilation and oxygen delivery. This is one of the major reasons why epinephrine is life-saving in anaphylaxis. In anaphylaxis, the patient is facing two problems at the same time: widespread vasodilation causing hypotension and bronchoconstriction causing respiratory distress. Epinephrine can address both problems simultaneously. Alpha-1 receptors help restore blood pressure, while beta-2 receptors relieve bronchoconstriction. And this is also why norepinephrine is not a substitute for epinephrine in anaphylaxis. Norepinephrine can certainly raise blood pressure through alpha-1 mediated vasoconstriction, but it lacks the significant beta-2 mediated bronchodilation needed to open the airways. Therefore, while norepinephrine is commonly used to support blood pressure in many forms of shock, it is generally not the preferred vasopressor in anaphylactic shock. Beta-2 receptors also play an important role in metabolism. as during fight or flight response, we need more fuel for working muscle. So, stimulation of these beta-2 receptors promotes glycogenolysis and gluconeogenesis, increasing the availability of glucose during stressful situations. At the same time, beta receptor stimulation in adipose tissue promotes lipolysis, releasing free fatty acids that can be used as an additional energy source. So epinephrine also mobilizes fuel stores so that the body has the energy needed to respond to that stress. This is also another way to distinguish epinephrine from norepinephrine. Norepinephrine is primarily focused on maintaining blood pressure and cardiovascular function during stressful situations, whereas epinephrine not only supports the circulation but also mobilizes the body's energy reserves to prepare for a true fight or flight response. Another interesting effect involves the pancreas. Epinephrine stimulates both alpha-2 and beta-2 receptors on pancreatic cells. While beta-2 receptors tend to promote insulin release, the alpha-2 effect is stronger, so the overall result is a decrease in insulin secretion. At the same time, glucagon secretion increases. Together, these effects help raise blood glucose levels during stress. This is clearly explained in Part 2 of our Sympathetic series lectures. Now the uses of these drugs. Let's start with cardiac arrest. Both epinephrine and norepinephrine can support cardiovascular function through their beta-1 receptor activity. By stimulating beta-1 receptors in the heart, they increase cardiac contractility and help restore effective cardiac pumping. Both drugs can also be used in hypotensive states because they stimulate alpha-1 receptors, causing vasoconstriction and increasing blood pressure, while beta-1 stimulation helps support cardiac output. In fact, norepinephrine is one of the most commonly used vasopressors when the primary goal is to restore blood pressure and maintain organ perfusion. Another important use of both drugs is as an adjunct to local anesthetics. Here, we are mainly interested in their alpha-1 mediated vasoconstrictor effect. By constricting blood vessels at the injection site, they slow the absorption of the local anesthetic into the systemic circulation. This keeps the anesthetic localized for a longer period of time, prolongs its duration of action, and reduces systemic toxicity. As we discussed above, during anaphylaxis, massive histamine release causes not only profound vasodilation and hypotension, but also bronchoconstriction. Therefore, this is where epinephrine becomes the drug of choice. The same principle applies to severe acute asthma. In this situation, the major problem is bronchoconstriction, so beta-2 receptor stimulation becomes critically important. Epinephrine can relax bronchial smooth muscle and improve airflow, whereas norepinephrine has little role because it lacks meaningful beta-2 mediated bronchodilator activity.